Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. This is Dr. Andy Cutler, Chief Medical Officer of NEI. And today I'm really excited to learn a little more about a topic that, to be honest, I don't know as much about, and I probably should. And with me today is Dr. Lisa Fortuna, who is the Chair of Psychiatry at the University of California, Riverside. Good morning, Lisa. How are you?
Good morning. Great to be here.
Well, thanks so much. Well, what we're going to be talking about today is a very timely topic. It's migrant and refugee mental health. And as we know, we have quite an issue of influx of folks to our country. Maybe we could start out with an overview of some of the mental health challenges that are faced by these populations.
Sure. I mean, of course, like any population, any community, immigrants and refugees are very heterogeneous, right? So coming to this country for asylum and many other reasons. And sometimes those relate to displacement in their home country for different issues that are either economic, but often violence exposure and violent situations. And for some refugees, it's actual wars. So as you can imagine, there's a high degree of diagnoses like post-traumatic stress disorder, anxiety, depression, that those communities are vulnerable to develop, right? And that relates to their exposures in their country of origin, and sometimes also related to their migration and things that they encounter in that process. And then, the stressors when they arrive in a new country.
Yeah, I can imagine it must be quite a decision to leave your country and to make this journey to try to find a better life, and the risks you're taking and the stressors and the trauma. It's really remarkable. And then this is a group, of course, that doesn't have resources to afford proper care. So yes. I can imagine there's a huge issue there.
Yes, no, definitely. And, in the research that I've done, people were at one point concerned that immigrants, migrants, refugees might be overusing our mental health services system because of the vulnerabilities that they have in mental health. And all of the research that I've done, epidemiological and clinical, have shown that they actually are under accessing, right, mental health services, even when there's need.
Sure.
Yes,
why
absolutely.
Is that? Why
it's a combination of, as you mentioned, the economic issues, having insurance to be able to access services, but it's also having services that are actually matched, right? That are accessible in terms of language, culture, and that can overcome either mental health stigma around accessing services, or that can actually overcome people's concerns about their immigration status.
Yeah, you're bringing up something I hadn't really thought as much about, and that is the cultural variability here of these populations. I mean, we're talking about people who could be coming from Europe or from the Middle East or from Latin America, which of course is a very diverse region, whether you're talking about South America, Central America, the Caribbean. So, of course, being culturally appropriate and getting culturally appropriate services is a major challenge. And then, of course, when you throw the language barrier into it as well.
Yes, absolutely. And it's, it's also that cultural matching, right? Because we can, as you can imagine, you can work with interpreters, which actually helps. But you also need that cultural understanding because, as you're mentioning, it's so diverse globally, right? The way people present their mental health symptoms.
Yeah, and then the cultural differences as far as acceptance of mental health and reaching out for help, if you will, the embarrassment, I'm sure, all of that. I'm thinking about several years ago, I was working with a woman who was Haitian, and we had, they don't speak Spanish. Even though they come from the Caribbean, we had a heck of a time finding an interpreter.
Yes.
So yeah, I can really imagine what you're talking about.
Right, right. And you need interpreters that are well skilled, right, in actually presenting. Because as you can imagine,
Yes.
I'm bilingual Spanish speaking, and I can speak with people, obviously, who speak that language. But again, the people are coming from all over the world, and you really need interpreters who can, explain back and forth, right, what the person's presenting in terms of mental health. You can imagine trying to assess psychosis across language.
Yes. Wow. Yeah, I hadn't thought of that too. They need to be a little bit knowledgeable about medical and psychological issues.
Yes.
So I'm trying to think now, what are some effective approaches to addressing these mental health needs of these communities?
I think some of the things that some of us who have been doing research in, how to support immigrant communities and refugee communities have found is that, one, some of our evidence-based treatments, many of our evidence-based treatments work to treat PTSD, depression, anxiety. So I'm, describing things like cognitive behavioral therapy can be very effective in treating post-traumatic stress disorder in adults and youth and children, right, who come with depression, anxiety, PTSD. And it's just a matter of, one, obviously having it accessible in language.
Yes.
And also having someone who can translate those, cultural ways of presentation. There might be some communities that present more with somatic symptoms, but we can still talk about, what they're experiencing or thinking or feeling and what's related to that. And so we've had some success in doing that. And then the other thing is bringing it out to settings where communities will access that, right? So we can have it within clinics, but we've also done things in churches and mosques who have been cultural brokers to help, say it's okay to talk about these things, integrating concepts of spirituality, which I've had to do, and been successful with Latino and also Muslim communities and thinking about how faith relates to their well-being. So it's really around this integration of where people are and having that cultural humility and language capacity to deliver evidence-based treatments that do work.
That is absolutely fascinating. The idea of finding an appropriate location, of reaching out into the community, if you will, and not just setting up a clinic and have them come to you.
No, yeah, definitely. I mean, we even had in Boston, we created a mental health clinic we called, community counseling within a refugee immigrant resettlement agency. And what was really worked well there is that we also worked with very qualified interpreters, people who had lived experience themselves of being displaced or refugees. And they were also getting support like navigation, case management, support around housing, which is another thing that we have found is very successful when you integrate addressing those other needs.
Yeah, I can imagine. Housing insecurity is incredibly stressful, I can imagine as well.
Yes.
You mentioned assessing psychosis, and it just occurred to me, of course, various types of therapies such as CBT certainly are helpful in the other conditions you mentioned, PTSD, depression, anxiety. But for psychosis, I mean, we've got to talk about antipsychotic medication.
Yes.
And there must be challenges in delivering that and in culturally getting someone to accept that and take the medicine and so on. How does that work?
Yeah, I mean, that's very difficult. And, again, it takes the ability to be able to assess appropriately, right? Because as you can imagine, across culture and language, that can be very difficult. You have to disentangle culturally appropriate presentations of things that might be seeing spirits or other visions, right? That might be culturally appropriate. So you have to work with good cultural brokers. But then once you identify that even, family members and others are saying this is unusual, this is not within a cultural construct, what I have found is you really have to work with supporters of that person and family and whoever they have that's supporting them, or create people who can, who can be those supporters that can wrap around that person. And sometimes it takes quite a while, still continuing to work with their basic needs, housing, if you really engage people in that supportive relational piece, we have been successful in having people accept medication. And when, they start feeling better, the combination of symptoms feeling better and that community of support sometimes is successful in engaging people in treatment.
Yeah, I can imagine. What is the usage of long-acting injectable antipsychotics like, and is there an acceptability around that? Because that's certainly one way to make sure somebody's getting their medicine.
Yes. Yeah, we definitely have done that, like in other patient populations. Again, after sort of building that trust, that absolutely is much more successful because you can maintain, symptom improvement, and then people are able to engage on the long run, right?
Yes. Yeah, and there's challenges, of course, delivering that type of treatment as well.
Yes.
I'm very curious about, you've referenced your research a couple of times. Could you tell me a little more about the kind of research that you have done and are doing, and what kinds of things you found?
Yeah, so, I've been doing research inclusive of immigrant populations since about 20 years. Part of what I started to research in collaboration with one of my long-term mentors, Margarita Alegria, who's in Boston, is, I started off looking at the National Latino and Asian American Study, which was a nationally representative epidemiological study of Latinos and Asian Americans. And it included a diverse group of Latinos, so we could look at, Puerto Ricans versus Mexican or Cuban, and actually looked at, rates of mental disorders, but also the social cultural factors that might relate to mental health disorder and distress. And it was a lot of things that we're talking about that were sort of social cultural issues, right? Like issues of acculturation stress or migration stressors, exposure to political violence and war, and also neighborhood stressors in the community that also were related to that, and family conflict, the disintegration of sort of family cohesion and cultural stress within the family, right, between youth and adults. Those were all related to mental health issues. And then over time, we developed some of the things that I have talked about here in terms of cognitive behavioral therapy and other interventions in different settings to see if that would improve engagement and treatment, and outcomes. And we have been pretty successful with that. And then my last, more recent research in the last few years has been really working with community-led and community-engaged research, where, I currently have a grant, and actually I'm the academic partner, and NIH has just created these grants where the community leaders are the principal investigators of the research. And so I'm doing that with a group that work with the Latino community in San Francisco, in the Native American community, and we're looking at structural determinants of health, things like economic stressors, food and housing equity, as issues around mental health outcomes over over a 10-year study.
My goodness, it's fascinating. And I'm just thinking, I do research as well, different kind of research, psychopharmacology. I'm imagining the research challenges here that you're facing. How to get this set up, how to do this kind of research. Can you tell me a little bit about some of the challenges you've faced?
Yeah, I mean, with I'll start backwards with this NIH community-led grant. What has been really successful there is that they're community-based organizations in San Francisco that are being very successful in supporting their community, and they were so during COVID. And they created their own participatory action research group. Paul Flores, who's an artist there, got a grant to support immigrant essential workers in learning about participatory action research, how to do investigations of their own community around the impact of COVID. And they engaged me because they knew I did research in the community. And it has been a long partnership in building trust, including community members, as they do in this particular project, as the investigators of their own questions. And that has created a great amount of trust. It's not a sense that I'm coming in and, getting data and then leaving and saying goodbye, but that this is actually questions and issues that we collaboratively work on. And that's been really successful. And even they, the investigators in the community have to build trust with the greater community of why we're doing this research. But, they're very successful because they really integrate things that people find important, and looking at cultural factors and cultural strengths as well, and creating interventions together. And I think to me, this is a very exciting pathway of doing research and having an impact with the community.
Yeah, absolutely. Partnering with the community is so important, and I hadn't thought about the issue of trust and how important that must be, especially for some populations who have a hard time with trust because of what they've been through.
Oh, yes. Rightfully so, right?
Yes, I would imagine, yes.
Yes.
You mentioned a couple of other things that I want to elaborate on just a little bit. You mentioned family, and I hadn't thought about that as well, about how important family is to some of these cultures. And you mentioned the Latinx community and the Asian community, which, of course, the family is so incredibly important and powerful. Could you talk a little more about that, and maybe how do you engage the family? How do you incorporate that into what you're doing?
Yeah, no. So it's interesting, even as we were doing a lot of the cognitive behavioral therapy, and we also, created some transdiagnostic interventions for, mood disorders, PTSD, and even, some, sort of subthreshold substance use disorders. And, we did not originally, interestingly, include a family component. And just to sort of keep it more in an individual therapy, right? And this is for, I've done so for adults, and with the youth, we incorporate a little bit more family work from the beginning. But even the adults felt, some, felt disconnected from family for different reasons and obviously didn't want them involved. But there was a good majority of people who said, this really needs to have a family component because what's really creating a lot of distress for me is, the conflict that I'm having in my family. They don't understand what I'm experiencing. And so we integrated sessions that were optional that would, if the participant wanted, could include this more interactive sort of sessions around family support. So, and that was very successful. And, and we found it even with the youth. There's some youth who, don't want their parents involved, but when we've done some cognitive behavioral therapy, they wanted their parents. I want them to learn the skills. I want our whole family to use it. I want them to understand what I'm experiencing as a young person, acculturated here in the United States. And there's some interventions, especially around suicidality, which we found family conflicts could be a very significant factor for suicidality in youth from immigrant families. And because of these conflicts and acculturation differences and many other things. And so those interventions were a lot more family-centered and building more mutuality and understanding about each other's experiences.
Wow. Yeah, I can imagine how important that is and what a challenge it can be.
Yes. Yes.
You mentioned youth and suicide, and of course, that's another thing that is so important and so topical right now. And we have such a crisis of suicidality, not only in the general population, but especially in our youth. And I can imagine that's only magnified in these populations that we're talking about.
Yes, it is. I mean, it's interesting. We're finding more and more, unfortunately, that there is an increased rates of suicidality and suicide in our country, right?
Yes.
That has been increasing over at least a decade. And definitely there are immigrant youth who are at risk because of some of these factors that we've talked about, feeling disconnected. And the research that we've even done in adults where we published a paper, looked at rates of seriously thinking about suicide and in a primary care and community sort of based settings. And we found, about 25 to 30%, depending on the setting, of people saying yes, that in the last month they've seriously thought of it.
Goodness.
In primarily immigrant populations. And we actually did this study in the United States and in Spain, which is the second largest, community of Latin American immigrants, right? Because I imagine it's a Spanish-speaking country.
Yeah.
And so, and that was, the actual suicide attempts were very low, but there was a high degree of serious ideation, which we published on because people said, well, at least there's not, they're actually attempting, but
Right.
but there was a significant level of distress, and and some of the main factors were the same. I mean, obviously having depression or anxiety, but also it was interesting. There was a factor that we looked at, which was belonging. And we asked about whether people felt that they belonged in their country of origin anymore, and also, or here also in the United States or in Spain. And those individuals, even when controlling for other factors, including diagnosis, having a low sense of belonging was related to increased suicidal ideation, as did, stress around citizenship.
Boy, that makes sense. The other thing this touches on is the larger epidemic of loneliness that we have in our country.
Yes.
And that is related, of course, when you feel you don't belong in any place. And the isolation and loneliness, I can imagine, is even more magnified in these populations. Have you looked at loneliness at all, or, as a relation?
I mean, I think we've looked at it at least indirectly, in the sense of, we didn't use sort of a loneliness measure, but this question about belonging, definitely questions around connection to community and neighborhood supports and resources, being active in culturally supportive settings, church, faiths, places of faith, and that those factors of being disconnected from many of those things were always related in our analyses of increased risk for, or odds of having mental health disorder.
Yeah, it certainly makes sense. And now I'm imagining youth trying to go to school. It's hard enough going to school to feel like you belong and to have friends and all that, but I can imagine here again how hard it would be to integrate and to feel belonging and to make friends and all of that.
Yeah, no, absolutely. And, and again, being a very heterogeneous community of immigrants, right? Some of the things that from Latin America even, there's subgroups of youth who are particularly, feeling disconnected. And some of our research, shown, youth who might be from Latin America, but also from indigenous communities who have experienced discrimination even in their country of origin, right? And then come here and are even more different than their Latino peers, let's say, in the United States, and feeling particularly disconnected.
Yeah, I can imagine that makes them vulnerable to bullying, to ostracization, being ostracized and so on.
Yes.
Now, you mentioned something else earlier that I wanted to touch on, and it relates to this. You mentioned neighborhoods, the concept of neighborhoods, and maybe you could elaborate. I wasn't sure exactly what you meant by that.
Yeah, so, some of the things that we were very interested in the National Latino Asian American Study, for example, was looking at things like neighborhood safety, right? Because we'll think about how, if you're experiencing a lot of violence and safety issues instead of security in your community, that's going to be a stressor. So we looked at things, like rates of violence and crimes, but also we looked at, positive things, right? In terms of, do you have a network of support? Is there a sense of social cohesion and resources in your community? Because we also know that sometimes when immigrants live in enclaves of that are culturally etched, or where they have community, that can be protective, but then you also have to balance that with, are there economic stressors or violence in those communities as well, right? So we were very interested in looking at how those things balance out. And as you can imagine, having a significant amount of social cohesion, a place of faith, neighborhood protective factors like that could help around mental health, right? Versus these increasing economic and other issues.
Yeah. Speaking of violence, have you found rates of violence that are particularly higher in any particular group or area?
It's really when we look at urban settings, right?
Well, sure,
where people tend to move to, even in some of these enclaves that I'm talking about.
Mm-hmm.
There is, that is one of the factors around experiencing violence. And, we're talking about, major cities and, New York. We've looked at Los Angeles. It's a tremendous amount of exposure to violence, and that has an impact for youth, right? In particular, everyone, adults as well. But, even just looking at schools that have had a tremendous amount of violence around them, where you can actually sort of put marks around where there has been, homicides and other violent crimes, and a high rate of, stress experienced by young people in those communities.
Yeah, I'm just imagining that a lot of migrant and refugee populations do end up, unfortunately, in disadvantaged areas.
Yes.
It's not like, they end up in the suburbs, I guess, or somewhere in middle America might be safer. So I can imagine that's another challenge. And also, these are often people who have already experienced trauma and violence, and now they're being re-traumatized. So that, of course, is going to reactivate any latent kinds of issues.
Yes, absolutely. It is really, as we know, how PTSD can be really an issue that's more complex and cumulative, right? And especially when we think about young people who, have developing brains and are developing psychologically, and then experiencing, a sequence of significant traumas.
Let's talk a little more about PTSD. Obviously, PTSD is different depending on many factors, such as the type of trauma and so on, people's coping skills and so on. What kinds of differences in the PTSD are you seeing in these populations, perhaps versus other populations?
Yeah, I think, they're experiencing, the trauma often of displacement, especially people who are forcibly displaced, which is really an issue of losing your place of origin, your connections, right, which we've been talking about, and combined with experiencing violence, directly violent threats,
right?
In some of the Central American countries where a lot of youth are coming from, they've experienced actual attacks, with guns and kidnapping, extortion. And then, during the migration process, unfortunately, they're vulnerable to physical attacks, sexual assaults, sexual trauma in their home country. And that's particularly seen in women and youth, but across the population. And then coming here, experiencing a lot of the neighborhood stressors that we've been talking about, as well as discrimination experiences, that all combines and to be very challenging, right? And the presentation tends to be what we think about in terms of post-traumatic stress disorder symptoms and meeting, DSM criteria. But it does take sometimes, especially with young people, some evaluation of that, because what we see is a lot of trauma-related cognitions and worries and school difficulties and a lot of things around identity formation, right, for youth.
Oh, I can just imagine trying to concentrate and learn in school when you've got all that going on.
Yep.
It's incredible. So, addressing PTSD specifically, if you don't mind.
Yes.
What types of interventions, you did mention CBT, are there other kinds of interventions that you found to be helpful?
Yeah, so One of the interventions that I developed was CBT based, but we also integrated mindfulness and wellness components to it. And it's interesting because I first did it with adolescents who were immigrants, and they really took to it very easily. I was wondering if they were going to think, is this mindfulness thing weird? But they really went into it, especially when we really focused on grounding and sort of how to sort of focus and calm your body. And so, there were some youth who also wanted to integrate moments of prayer because spirituality was very salient for them. And we were able to integrate that and to have the experience of being able to calm oneself and to focus and to feel moments of refuge, essentially, from the feelings of stress was really helpful. And it was one of the things that we had to start off with every session before we can even think about thoughts, because it was actually much harder to think about what am I thinking in this sort of CBT way before we actually had the practice of being really centered in oneself. Because there was a lot of sort of orientation to avoiding thoughts, as you can imagine, which is, what we think about in PTSD anyway, but also trying to just compartmentalize, right, what has happened to me so I can survive, which makes perfect sense. But to be able to sort of focus and be in connection and awareness of oneself was very helpful.
Yeah, I can imagine, but I'm just sort of laughing to myself. What did you call this? How did you introduce this? I can't imagine calling it mindfulness would get buy-in. Did you use different terminology?
Yeah. So, it's interesting. In Spanish, we're using different terms. Sometimes we say, speak in Spanish and say mindfulness. Another way that it's been called is atención plena, so it's really focused on attention. And
I see.
And really sort of talking to them about it's not just meditation. It's not putting your mind in blank, because that's what some people are like, I can't blank out my mind.
Right.
It's and for some that's like a spiritually inappropriate thing, right? To sort of make yourself blank. But what we talked about is just really building your attention and awareness to yourself, so that then you have the opportunity to have some choices about what you want to do to help yourself. And that worked.
Wow. Yeah, I can imagine the concept too of relaxation techniques. So these are people who are just, gosh, I can imagine their cortisol's off the charts all the time, and they're just chronically stressed, and their vigilance, they're just hypervigilant all the time. So just to be able to learn how to calm yourself and relax yourself.
Yeah, exactly. And how to, I think for a lot of the adults, they loved the idea of, relaxation, feeling calm, reducing that level of stress. And for the youth, I had to really sell it that it actually builds up your game to actually understand. I told the youth, some of them who had always experienced, threats of gang violence and other things, right? Where they felt they had to, of course they had to be vigilant. It's real, right?
Yes.
And so, and in their communities currently, there might be violence. Well, I have to be vigilant,
Of course.
And so I said, absolutely. What mindfulness helps you do is to actually figure out, what do I need to pay attention to and what might not be the thing I need to pay attention to. It builds your game. It reduces the static, is what I told them. And that helped.
Yeah, I can imagine. I like the term builds your game. It sounds like that resonates with people.
Yes. Especially adolescents.
Yeah, you're on your game. Exactly. Yeah. Well, one other thing I wonder, did you incorporate exercise into this, since you're talking about being holistic here? I can imagine these are people who haven't been able to engage in exercise. And of course, exercise is beneficial in so many ways.
Yes. Yeah. So, it's interesting with that intervention that, I said I first created with youth. mindfulness-based CBT, it also had movement activities like yoga and stretching and mindful walking and running, and how to sort of integrate those things. And we also did some art, you know, and so some art therapy and how do we integrate a mindfulness approach to that. And one young man I remember did a lot of mindfulness practice and then created music, lyrics that were related to some of the things that he was learning in like a reggaeton, like Latino reggae, you know, rap kind of way, right? So, and he would share that, you know. So, you know, what I like to, you know, I think when we have a lot of creativity and bring in, you know, our evidence-based treatments, but also integrate the way people express things, I think it's wonderful. And we're doing that with our community grant now, where, you know, they're doing, you know, indigenous dance as well as, you know, cooking and integrating mindfulness and cognitive behavioral therapy techniques.
Wow.
And there's a hunger for which I was very pleased, like integrating these things. The best of both worlds is what, you know, they're describing.
Yeah, boy, is that fascinating. I know how important music is in some of the cultures specifically we're talking about, and dance and creativity and art. I hadn't even thought of that. And of course, they haven't been able to engage in that, I'm sure, throughout the migration and the journey they've been on.
Exactly. And then when we have these centers, which, you know, the immigrant population, Latino population in San Francisco is really trying to create a center of cultural healing, is what they describe, which invites, you know, therapists to assist in this way, but they also want to build some of the things that we talked about are risk factors, you know, to overcome that, right? Which is, you know, supporting people with economic development, supporting people with community and connections, and cohesion, all those things that we saw back, you know, a decade ago or more in the NLAS were risk factors. They are identifying those are the things we need to address, right? We need to build up those resources, and integrate, you know, these behavioral health constructs as well. And then it really destigmatizes it, right? It makes it something that is within our realm of participating in, and not just, you know, what psychiatrists and psychologists deliver in a room, right?
Well, yeah, I mean, I'm just thinking if you're in survival mode, it's very hard to indulge in these other aspects of humanity. So you almost have to give them permission and help them rebuild their humanity in some ways, the things that make us human.
Yeah, yeah. And you're pointing to something really important. I think, you know, this whole issues of discrimination and lack of belonging and not being a citizen, I think you can want a very potent stressor is exactly what you're saying, is feeling dehumanized, right?
Yeah.
Feeling disenfranchised and dehumanized and disconnected. And we know that those are very significant issues for mental health, and that social support is very good for our mental health and our resilience. So, you know, those have to be part of the equation.
Yeah. The other thing this touches upon is we know that these are huge risk factors for all kinds of medical illnesses, other medical kinds of illnesses. And we know that some of these populations, such as Latinx, are even more vulnerable to things like cardiovascular disease, diabetes, and things like this. One of the things that was surprising to me, learning a little more about the loneliness epidemic, is not only, of course, the relationship to mental health issues, but the relationship to physical conditions, medical conditions. I wonder how do those things interact in what you're doing and maybe in delivering care?
Yeah, so it's interesting. We absolutely, you know, we have seen so many health-related issues. I mean, just if we look at post-traumatic stress disorder, right? We know that people with PTSD have a higher rate of all kinds of chronic illnesses, right? That, you know, might be related to, you know, that what you were mentioning, elevated stress hormones and other factors. And so we see that in the community, as well as, you know, living in under-resourced and disenfranchised communities, where there might not even be a high quality of food and vegetables, right?
Well, yeah, of course.
And
lack of physical activity.
Lack of physical activity because you don't feel safe in the neighborhood. And so, and for youth, that sort of disconnection that they might experience here and lack of physical activity as compared to their home country, increased rates of obesity, right? Which relates to, diabetes risks for even youth. So we've looked at that outcomes, and that's one of the things that we're looking in the new study of the structural determinants of health in San Francisco. We're looking at mental health outcomes, but also some of the what we're calling stress-related, illnesses that we might think about, like diabetes and cardiovascular disease and obesity over time. Because they really are trying to look at both mental health supportive things as well as food and housing and other things that might absolutely relate to health, physical health as well.
Yeah, with PTSD, of course, your sympathetic nervous system is chronically on overdrive, and we know that is very dangerous for your cardiovascular system, for development of heart disease and so on.
Yes.
And it makes me think about when you were talking earlier about some of these holistic kinds of things you do. The idea of just learning more about diet, fitness, physical health, I can imagine that's an important component of this as well.
It is, and again, the participatory action researchers, they in San Francisco, they honed right into that. They started to create, and especially during the height of the pandemic where we were all in the house and as soon as they felt that it was safe, they started to have group walks, right? Where we're actually walking and moving and talking and supporting one another. And so they would walk, all around, San Francisco. They started to increase their dancing program and really promoting physical wellness. And they recently did a study looking at long COVID symptoms in the community, and are starting to promote an anti-inflammatory diet, which is more plant-based, and actually more rooted in their food traditions and how to do that in a healthy way, and have had events where they cook that, and so it's really exciting how they're looking at this holistically.
Yeah, I love the idea of the group walks and the dancing because you're addressing both the exercise component but also that issue of loneliness and social interaction. You're sort of getting a 2-for-1 deal there.
Absolutely. And one of the interesting things is, I went on some of these walks, and they were so joyful. They were families, right? Like little children who were walking, and for some of them, the first time they did it, they thought about their migration experience.
Oh my,
and but had a way to reframe that, right? Walking and talking together and hearing each other about that experience and having this very positive walk.
Yes. Wow, I had not thought of that. My goodness. It's the idea of walking together was during your migration, your journey. My goodness.
Yes.
Wow. Well, there's one other issue that we have touched on, but I'd like to talk a little bit more about, and that's the issue of substance abuse in this population.
Yes.
Are there certain substances that are more likely to be abused, and what are some of the issues around that, and perhaps around delivering substance abuse treatment?
Yeah, so, alcohol, I would say is at least when we've done studies, has been the most common substance that has been a significant risk.
How much of that is cultural? How much of that is access to easy access?
Yeah, I think part of it is access, and I think it's also there's some component around cultural. So there's been different studies that have looked at that a certain degree of heavy drinking might be very acceptable, especially amongst men in certain Latin American countries, and so that can easily escalate, right? If it's also related to managing stress as well.
Right.
So that's one of the things, and nicotine is the other issue.
Oh,
a lot of immigrant
of
populations, right? Sure. If we think about that as a drug. But obviously in other urban settings, there's always a risk of the other drugs and substances that are around. And if people become unhoused, the relation with meth and opioids, unfortunately.
Mm-hmm. Mm-hmm. How about marijuana?
Cannabis, yes. I would say even more amongst the younger groups, adolescents and young adults. And vaping, unfortunately, has become an increasing risk around immigrant and youth of color. And some studies showing that it happens in similar ways as other youth, socially, but that young people of color, including immigrant youth, are reporting that vaping also has an added factor of reducing their stress. More likely to say that than their American white counterpart.
That is fascinating. So they see it as almost an adaptive type of thing. Yeah. My goodness. I hadn't thought of that either. Vaping, it is very accessible.
Yes.
Too. Especially in urban areas, there's smoke shops. These places they call smoke shops.
Exactly.
Yeah.
Every corner almost, yeah.
Yeah. I'm also about delivering care, delivering substance use treatment services. How does that work in this population?
Yeah, I mean, I think there's some similarity, right, to what we've been talking about, sort of approaches to PTSD or depression. Again, there is definitely even, I think, a higher stigma, right, of thinking about that I'm having an addiction.
Yes.
And so you have to be, again, creative. You need to be in settings that will have, the language and cultural capacity to be able to serve communities that are diverse. And then also, looking at there are more and more centers that are focused on serving specific populations of immigrants in urban settings, and I think we need more of those. We need more substance use treatment.
Yes, we
in general for
do.
Everyone, but we definitely need ones that are, culturally embedded, accessible, and affordable. Because actually, people being able to do that is very difficult. And some of the things that community-based organizations are doing are creating culturally appropriate care that is also evidence-based, which is very difficult to get. And especially with our, in San Francisco, one of the groups that we're working with on this project is a substance use disorder serving organization that provides treatment and also cultural support around indigenous communities, Native American communities, and even urban Native American communities in San Francisco, and Latinos. So again, I think it takes the same level of integration and outreach and responsiveness of working with the particular preferences and needs of the community.
Yes, well, you touched on something, of course, that is wider, that we have a real problem with the way we handle substance abuse in our country. Unfortunately, we criminalize it and we stigmatize it, if you will.
Yes.
I heard a news story just 2 days ago about Portugal.
Yes, I did too. Yes.
Did you hear that? Yeah, Portugal treats this as a health issue.
Yeah.
And they have an incredibly lower rate. For instance, I think it was only 80 overdose deaths last year. It's something incredibly low. You're 455 times more likely to die of a drug overdose in the U.S. than in Portugal when adjusted for the population size.
So. And what I thought was really interesting, people were saying, well, can we do it here? Yeah. And one of the factors I think that they're questioning is, do we have the same kind of community connections, right? That people are really experiencing in Portugal. I mean, it was one of the factors. Where, even the police, is interesting. They were in that talk, they were asking an unhoused person. He says, well, the police are friends. They're here to support you, when I have needs. And so it's, and also other people supporting them, and also that you have access to health. I mean, I think the other thing is, we need, they mentioned we need more accessibility to affordable or free, health care that you can actually access on demand when you need it, right?
Absolutely. They also talked about housing and, interestingly, job training, which I hadn't thought about. And again, I imagine that's an issue with these communities that we're talking about today.
Yes, exactly. And that's exactly why, over the years that I've been doing research and looking at these connections and then being able to work with community members, they are clear, that we have to identify and address those structural determinants of health, right? The unhoused, the economic stressors, as well as food security and access to the appropriate health care. And they're looking at that multidimensionally because that's really what we need.
Yeah, certainly is. Well, I have to tell you, Lisa, this has been a fascinating discussion, and I can't believe we're coming to the end of our time.
Yes.
But I'm thinking about our audience, people who might be listening who maybe haven't been as involved in this kind of work, but yet the migrant and refugee issue is spreading across the country, and folks are ending up in many different communities, not just sort of traditional cities. I'm wondering, is there any advice you can give some of the people who might be listening, some of the clinicians, on how to be more alert about this, how to communicate with other disciplines, with other people who may be working in this area? What can we do to be more sensitive to and more helpful to these populations?
Yeah, I mean, I think, the most important thing to begin to learn about what can be done is to go to who else are the helpers, right, in the community. Places of faith, churches, mosques.
Yeah, that's a terrific suggestion. I hadn't thought about. Yeah,
are highly important, right? I mean, that's a place where people center to get all kinds of support, not just religious and spiritual support.
Yes,
basic needs, and community-based organizations, wherever they exist, are always organized around supporting those communities, and they are excellent partners in thinking about how to support people from the mental health perspective, addictions, health. And then, some of the things that we've really been successful in is starting to train and incorporate people from those communities in being, peer support partners, family navigators. They're and then helping them sort of work up towards other health professions, including psychology. But even just having those paraprofessional peer support, people can make a lot of difference in engaging the community. It takes partnerships, and we can provide our quality care, with interpreters within our clinical settings. But it's really important to work collaboratively with other people in the community, because that's where the needs are, and that's your partners in helping in all these ways.
Yeah. Well, thank you. That was terrific advice, and this has been very practical and helpful, I hope, for our audience. And I really want to thank you for your time, Lisa. I know how busy you are as a researcher and a chairman of an academic department. So thanks so much for joining us today.
Yeah, thank you so much. This was really fun to be able to talk about this, and it always stimulates me to think about even more things to do.
Well, that's great. We all have plenty to do. Well, I want to thank you to our audience for listening in. I hope you found this enlightening and helpful. And for more resources, more educational offerings, please go to our website, www.neiglobal.com. And thank you so much, and good luck with your clinical work.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.